Good evening. It's a pleasure to welcome you to the December edition of the ESTS Webinar series. Today with the topic of novel aspects of immunotherapy trials in non-small cell lung cancer. There's really been a tremendous development in this field of perioperative immunotherapy in the last years. And it's a particular pleasure to welcome Professor Hauke Winter from Heidelberg today to talk about the exciting new aspects of current and ongoing trials of immunotherapy in NSCLC. Hauke, please.
Dear Clemens, thank you very much for the introduction, and hello to everybody. I guess that you all are aware that I'm not an oncologist, so my sight on tumor immunology will be more on the side of the thoracic surgeon and all aspects that we have to deal with. And I hope and try to give an overview on the past trials and on those that are still ongoing. These are my disclosures. All of you, or most of you, will be aware of the situation and the survival curves of patients that are deemed with lung cancer. And although for those with an early stage lung cancer in stage 1A and 1B, it is all but good, as most of those patients that have advanced tumor stages with larger tumors or with positive lymph nodes will have a very bad overall survival. So the idea to increase the survival by adding systemic therapy is kind of an old idea, and was reviewed in 2010 about the aspects of adjuvant chemotherapy for patients that were operated on for lung cancer. And that's on the left-hand side is shown, and the red line here, those patients that received surgery alone versus those patients that received surgery plus chemotherapy in an adjuvant setting had an increase of their survival by about 4%. There was no big difference for those patients that were treated with surgery and radiotherapy, and those that received chemotherapy on plus of on the surgery and chemotherapy regimen, as shown in the blue line. The survival benefit for all of these patients was about 4%. This did not really change when the idea was looked at that the chemotherapy was given in a neoadjuvant setting. Again, the survival benefit for patients treated in a neoadjuvant setting prior to surgery increased the survival likelihood by about 5%, which is good. At least it is something to see, but it's not really overwhelming. So therefore, we have to think about other ways to improve the survival of the patients. One, of course, is technical innovations, but so far we were not able really to show that by minimal invasive surgery or by robotic surgery, we are able really to improve the survival of patients, especially in the with larger tumors and lymph node involvement. So with upcoming immunotherapy, the idea kind of grew up that possibly induction immunotherapy or adjuvant immunotherapy would add to the survival of the patient and might increase the survival likelihood of our patients. And what are the advantages of treating patients in a neoadjuvant setting? So most likely it's the best possible way to treat a patient because he has not received any surgery yet and will be in a fairly good condition to receive neoadjuvant immunotherapy. There is, due to the existence of the tumor in the body, the maximum tumor antigen interaction with the host. So that might be also a very good scenario to induce tumor-specific immunity. Then the early therapy also might be able to reduce and to treat potential micrometastases that are not seen by PET-CT or CT scan. The therapy success can be estimated early on, as after the neoadjuvant therapy, we will hopefully be able to operate on the patient, and on the specimens, the pathologist will be able to tell whether or not the chemotherapy and or immune therapy has had an effect on the growth of the tumor. It's very likely that giving immunotherapy prior to an operation the compliance will be good from the patient, and also the pathologic analysis, as already said, will be good. Also, it is very likely that we induce an immune memory in our patients when we treat the patients still with the tumor on board. Of course, there are also some contra aspects to giving a neoadjuvant or adjuvant immune therapy. Especially with the neoadjuvant setting, there is always kind of a time delay between the treatment that we give to the patient and the operation. The tumor might progress due to the delay of the surgery, and we will face in some of the patients an increased complication rate due to the immune therapy. Also, it is likely that we overtreat the patients, especially in those patients with a very early cancer stage, and we will see drop out of potential curative patients that might be operated on or might have been operated on, but will not be operated on due to potential complications that they have been seeing during the neoadjuvant therapy. There are many different ways of adjuvant and neoadjuvant immunotherapy. I don't want to talk about those patients that have molecular alterations or driver mutations that have fairly good possible therapeutic ways to be treated. But talking about all those patients that do not have any driver mutations, the immunotherapy can be given and applied prior to the surgery in a immunotherapy way. So the very first trials that we saw were monoimmunotherapy trials. That can be a combination of two different immunotherapy compounds like PD-1 or PD-L1 together with anti-CTLA-4. That can be the immunotherapy given together with chemotherapy, like in the Checkmate 16 trial that was just published recently. Or, of course, there is also a combination possible of radiotherapy together with immunotherapy, followed always by operation, and then with an adjuvant possible further chemotherapy, immunotherapy, or radiotherapy. The question that we always have to ask is, what is the value of the primary surgery for the patient? Is there any specific therapy sequence that we have to go? And on what basis, on what evidence do we make the treatment decisions for our patients? If we look at all the different aspects of chemotherapy, as mentioned, the very first attempts were made with an adjuvant platinum-based chemotherapy and published in 1995, and also the neoadjuvant setting with platinum-based chemotherapy and radiochemotherapy, also starting in 1995. The first approval of immunotherapy was given in 2015 for nivolumab for stage 4 patients, and in 2018 for durvalumab for stage 3 patients. The very first trial that was published, and I will come to this a little more detail later, was by Tim Ford in 2018 with the neoadjuvant monoimmune therapy. The largest trial that were published recently, and that I will also discuss later, are the trials published in 2021, the large Checkmate 816 trial with a neoadjuvant chemo and immunotherapy, and also a phase 3 neoadjuvant trial, the same trial where we were given some survival data in 2022. Two other trials in an adjuvant setting were published in 2021, the Empower 010 trial, and in 2022, the Pearls Keynote 91 trial. Now, what is the evidence for all of those different trials? The first ones I want to talk about is the neoadjuvant monoimmunotherapy trials for operable patients with non-small cell lung cancer. Here is a list of different trials that were performed and as recently shown and published by ULAS in ESMO Open in 2021. The very first one is listed down here by Ford et al. That I was already talking about, with 22 patients with stages 1 till 3 and monoimmune therapy in the case of Ford with nivolumab, treating patients with 2 cycles with 3 milligram per kg over 2 weeks. The primary endpoints in this trial was safety and feasibility, as for almost all of the other trials that were also done with a monoimmunotherapy. 21 patients in this trial were staged from August 2015 till October 2016. 81 of these patients that were enrolled were stage 2 to stage 3A, and all of them were given 2 cycles of nivolumab. The outcome was pretty impressive, with about 45% of the patients, so 9 out of 20, with major pathologic response, with less than 2% vital tumor cells in the specimens that were resected. There was no or little influence on the technical operability in these patients seen. And interestingly, when you look at the PD-L1 expression, major pathologic response, so pathologic response where at least 10% or less of the tumor cells are still left over as vital tumor cells, we're seen only in 3 of 5 patients with PD-L1 positive expression, and no major pathologic response in 4 out of 10 patients with PD-L1 positive state. Another trial, the LCMC3 trial, looking at neoadjuvant immunotherapy with atezolizumab, which is an anti-PD-L1 compound, treated altogether 181 patients. The mean age of the patients enrolled in this trial were 64.6 years. Most of them were male, about half of the patients included were male. 22% were active smokers, and 65% of the patients included had a non-squamous histology. There was a mixture of stage 1B with almost 11% of the patients to 3B patients with 6.9% of all the patients. An extensive hilar fibrosis was observed in 20 out of 90 patients enrolled, which makes about 22% of all the patients. No surgery, or surgery could not be performed in 22 of the patients. That means 12% of the patients dropped out due to radiographic growth of the tumor or other reasons. These are data from our own trial, the Newman trial, which started almost together with a Ford trial, and also including patients with stage 2 till 3A. We recruited altogether 30 patients, with 1 patient dropping out because he didn't want to receive the treatment. We gave pembrolizumab with 2 cycles with 200 milligrams over 3 weeks, and surgery was performed again 3 weeks after the last dose. We operated 29 of the 30 patients, as I said, because 1 patient dropped out. We had no conversions, very little hilar fibrosis seen in our patients, and the R0 resection rate was about 100%. The major pathologic response rate was 24% in our patients, and the complete pathologic response rate was 14% in our patients. A lot higher response rates were seen when the immunotherapy were combined in the neoadjuvant setting together with chemotherapy. And all of those different trials that have been performed are listed here, again, as listed by the recently published paper by Ulas in 2021. The most well-known paper, for sure, was the one by Ford et al., the Checkmate study, with randomization of 179 patients, again, all of them in between stage 1 and 3, combining nivolumab together with platinum doublet prior to surgery. Altogether, 358 patients were enrolled, and they were then stratified to either receive the platinum doublet in combination with nivolumab or only chemotherapy. And surgery was performed after re-evaluation by radiological restaging 6 weeks post-treatment. Interestingly, those patients receiving immunotherapy in combination with chemotherapy, more of those were operated on minimal invasively as compared to those just receiving chemotherapy. The rate of patients that had to convert from minimal to open surgery were also less in the group that received chemotherapy together with immunotherapy as compared to the group of patients just receiving chemotherapy. One bad aspect of the study is for sure that there is a very high rate of patients in both arms, in the arm receiving chemotherapy and immunotherapy, and in those patients just receiving chemotherapy that did receive an R0 resection. So only 83% of those receiving chemo and immunotherapy and 78% of those only receiving chemotherapy were resected in an R0 manner. And all the rest had an R1, R2, or Rx resection, which is, in my eyes, pretty poor. Very positive is that the pathologic complete response rate in these patients was very high in the patients receiving nivolumab and chemotherapy, with 24% compared to 2.2% in those patients just receiving chemotherapy alone. The events-free survival was a lot better in those patients receiving nivolumab plus chemotherapy as compared to patients receiving only chemotherapy. Another combined immunotherapy and chemotherapy study was the NADIM trial, adding nivolumab to patients receiving paclitaxel and carboplatin. 46 of these patients in this regimen had stage 3A. 41 patients were operated, which means 85% of all those receiving neoadjuvant treatment were operated on, with an intriguing pathologic response rate of 83% in these patients and a complete pathologic response rate of 63% in the patients treated with immunotherapy and chemotherapy. In our own trial that we are just recruiting patients to is the IREP study, which is a study combining neoadjuvant chemotherapy together with atezolizumab, and patients receive carboplatin plus nab-paclitaxel. The very first patient that we enrolled had a large tumor in the left upper lobe, as seen here in the CT scan, which, although it seems it did not invade into the thoracic wall. The patient just got one cycle of chemotherapy and atezolizumab due to diarrhea and neutropenia that the patient developed. Almost several weeks later, preoperatively, when we performed the PET-CT scan as a follow-up after one dose of
Well, there seems to be a connection issue. I'm trying to solve that. Okay, so he should be back in a second. Okay, there is again. Hauke, can you hear us? At the moment, I can just see the screen. Yeah, now you're
Kannst du mich
back.
wieder sehen?
Yeah. Now you're fully back again. We can.
Great. Where do I need to go back to? Where did I drop out?
You dropped out at the first slide of your case presentation of the IREP study.
So here? This one?
Yeah, well, no, one ahead, I think, where you were showing the tumor in the apex.
This one?
Yeah,
Okay.
yeah.
Good. So I apologize for dropping out. I hope everybody is back online with me now. So the second case in the IREP study that we treated with neoadjuvant therapy of atezolizumab plus carboplatin and paclitaxel is shown here with a large tumor in the left upper lobe. And after receiving 3 cycles of combined chemo and immunotherapy, we saw a very pronounced immune flare on both sides of the hilum, something that we saw in our monoimmune therapy trials as well as now in the combined trial with chemotherapy plus immunotherapy, and which puzzled us in the very beginning a lot, but now it keeps us pretty cool because all of these patients so far were shown not to have a tumor growth in these lymph nodes, but rather a very good therapy which showed a very good therapy. Now, what we have to ask ourselves is, who will benefit from the neoadjuvant immunotherapy, and what is it with the pathologic response? Does it really translate into better survival? And most important for us is, will these patients stay and be operable or not? And does it influence the resection rate, depending on what we do with the patients prior to the planned surgery? And what is the extent of the resection that we should perform? And do the study protocols transfer into clinical practice? And last but not least, and which is most important to all of us, does this really translate into survival benefit to the patient? When we look at the major pathologic response rates and the pathologic complete response rates in monoimmune therapy trials, those are the ones shown here with a kind of blue shade, and those with the combined chemo and immunotherapy trials shown here on the right-hand side. I'll just start on the left-hand side with the monoimmune therapy trials. They are here shown in red bars for all the different trials performed for the major pathologic response, and for the pathologic complete response in green bars. So what we saw in the monoimmune therapy trials is that about 10% of the patients showed a pathologic complete response, and in between 5 to 40% major pathologic response, whatever this means for the survival of the patients. When we are looking at the chemoimmunotherapy trials that are now coming up, we see a lot better rate of patients with higher major pathologic response rates, as shown here, and again, the red bars, and pathologic complete responses, as shown here in the green bars, which range up to 60% in the different trials, with normally 2 to 4 cycles of chemotherapy and immunotherapy. But which is also very important, as I just mentioned, is the failure and the delay to undergo surgery following immunotherapy trials. Again, on the left-hand side, in blue, are those patients just receiving monoimmunotherapy. The rate of failure to undergo resection are marked here in blue bars, and surgical delay in green bar. I think surgical delay is possibly not that important, but if patients, especially in an early stage 1 or 2, drops out of surgery, I think this is a really big problem that we are facing. And even, and especially in the monoimmune therapy trials, we saw up to about 10 to 12% of the patients dropping out of potentially being resected, which is higher in the combination chemo and immunotherapy trials as shown here, by Ford, Rothschild, Tail, and Young, which showed failures to undergo resection in up to 40% of the patients. Furthermore, something that is very important also to keep in mind is that a lot of the patients that are treated with immunotherapy alone or a combination of immunotherapy and chemotherapy will develop immune-mediated side effects, which can be seen in endocrine organs, in the liver, in the skin, in gastrointestinal tract, and the lungs themselves, with the most common immune-related adverse events being seen in the skin and gastrointestinal problems, but also not few patients develop problems in the endocrine areas, the liver and the lung. Here I show you some patients that we treated in our immunotherapy trials, the NEOMUN trial, and are now being treated in the other trials, the combination of chemo and immune therapy. So there's not one of these complications that we have not seen so far. As shown here, patients with thyroiditis, patients with colitis, patients with dermatitis, and Lichen-Huber. And all of these patients will need to be treated, most of them with cortisone, and we'll see and will have a delay in their surgical therapy. Therefore, I think it is very important as a surgeon to discuss these patients together with the oncologist to make sure that these patients will get to their surgery as soon as possible and the amount of cortisone is not as high as possible. Immune-mediated side effects were also seen in other trials, like in the LCM3 trials and the Checkmate 816 trial. These are data from the LCMC3 trial, patients from stage 1B to 3A treated with anti-PD-1 with serious adverse events seen in 30% of the patients and adverse events leading to treatment withdrawal in 5% of the patients. Also in the Checkmate 816 trial, we saw a high number of patients developing therapy-related adverse events. So this is something we all have to be aware with and we all have to get involved with to discuss these patients in tumor boards together with the oncologists. Also in the NeoStar trial, there were kind of a high number of grade 3 to 5 related adverse events like pneumonia, pneumonitis, diarrhea, and many of these patients were in a very early tumor stage. So patients treated with nivolumab and ipilimumab completed only 90% of the patients, and surgery were only performed on 80% of the patients, meaning that 20% of these patients dropped out of the surgery, which I think is a very severe number. Looking at the possibilities of surgery, again, from our own patients treated here in Heidelberg, I just wanted to show you some pictures of the patients here. One treated with monoimmunotherapy in the NEOMUN trial with some moderate adhesions in the aortopulmonary window that could be managed with a normal minimal invasive surgery by VATS. But there were other patients like this one, also from the NEOMUN trial, that developed a very high immune flare on both sides of the hilum that had to be operated in an open way due to very strong adhesions of the lymph nodes in the hilar central region. This is also showing all this fibrosis centrally in the lung. So this is something to be aware of in those patients treated, especially with immune and chemotherapy. What we believe is that especially the minimal invasive surgery performed by robotic surgery might be of a great advantage, especially in these patients as shown here, treated with chemo and immunotherapy that had an immune flare, and preparation can easily be, or a lot easier be performed, I think, by a robotic surgery than it may be performed by classical minimal invasive surgery. But it is a challenge for thoracic surgeons to cope with, and might also lead to a higher rate of operations being performed in an open manner or after conversion to make sure that these lymph nodes can be removed safely for the patient. You can see in the hilar region those adhesions that are easily to be managed in a robotic way, but can also, even with a robot, may cause some severe problems. The question always is whether or not the PD-L1 expression is helpful to be able to predict whether or not the patient will respond to the therapy. When we look at the LCM3 trial, the NeoSTAR trial, and the FORD trial, and looking specifically at the amount of patients that were PD-L1 positive, we saw in the LCM31 trial major pathologic responses in PD-L1 positive patients in 8 out of 11, and no major pathologic response in 26 out of 57 patients that were PD-L1 positive. In the NeoSTAR trial, almost the same picture, major pathologic responses seen in 3 of 3 patients that were PD-L1 positive prior to surgery, and no major pathologic response in 3 patients of 10 that were PD-L1 positive. And the same was also seen in the paper by Ford in the monoimmunotherapy trial. In the CheckMate 816 trial, again, the PD-L1 expression in patients with less than 1% of PD-L1 expression, the survival curves were for those treated with nivolumab plus chemotherapy and those treated with chemotherapy alone, almost exactly the same, with no significant difference in survival. Whereas we saw a big difference in those patients that had a PD-L1 expression of greater than 1% for those treated with nivolumab and chemotherapy, as opposed to those that were treated with chemotherapy alone. Nevertheless, and very interestingly, those patients with stage 1B and 2 that did not seem to be a survival benefit for those treated with nivolumab and chemotherapy as compared to those treated with chemotherapy. This was different for those with an advanced stage 3, as shown here, where we did see a big survival difference for those treated with the combined therapy of nivolumab plus chemotherapy, as opposed to those just treated with chemotherapy alone. One idea was to assess the possible reaction to the chemotherapy by the tumor mutational burden, which was first published by Ford et al., who were able to show in their patient cohort that patients with a high tumor mutational burden would also have a high likelihood of a major pathologic response, as opposed to those who did not have a pathologic response and did not show a high tumor mutational burden. In the LCM3 trial, this could not be shown, as patients with high tumor mutational burden, as well as those with low tumor mutational burden, had the same amount of pathologic response. So until today, the significance of the tumor mutational burden on the outcome of the pathologic response is still unclear. The problem that we face in many trials is the differences in which the tumor stages are evaluated. Like in the CheckMate 816 trial, 63% of the patients stage 3A was staged by the clinical stage. In the Empower trial, 40% of the patients staged by 3A are in the pathologic stage. So there is a big difference, and which makes it very difficult to combine the results of these trials. As mentioned before, in the CheckMate 816 trial, what we saw is that in those patients treated with chemotherapy and immunotherapy, only 83% received surgery, as opposed to only 75% of those who received chemotherapy alone. This was a lot better in the NADIM-2 trial, where almost 93% of those receiving chemo and immunotherapy could be operated on, as opposed to 70% of patients just receiving chemo. So the combination of immunotherapy plus chemotherapy seems to be okay, and at least in the NADIM trial. There are some other aspects that have to be closely looked at when we talk about the CheckMate 816 trial. When we compare the results from North America to the results from the patients included in Europe and Asia, then it's kind of striking that the amount of patients treated minimal invasively in the CheckMate trial were 43% in North America being treated minimal invasively, as opposed to only 3.4% of the patients treated in Europe and 33% of the patients treated in Asia. So obviously in Europe, most of the patients were operated by open surgery. The R0 resection rate, as I already mentioned, was pretty poor in the patients included in the United States, with only 65% of the patients being R0 resected in North America, as opposed to almost 90% in the patients treated in Europe and Asia. Furthermore, the patients just receiving chemotherapy, the R0 resection rate was only 50% in North America, and 88 and 88.7% in Asia, a lot better. So I think this is something also to look at and to be aware of, that an R0 resection rate has to be accomplished in all of those patients that we put into those trials, and should not be as low as shown in many of the patients treated and put into the trials in North America. There are two more trials looking at the adjuvant treatment of patients following surgery. One of the large trials is the Empower 010 trial that treats patients with atezolizumab, which is anti-PD-L1 following surgery. The survival of these patients was shown here to be significantly better than those patients that did not receive an adjuvant immunotherapy. The overall survival of the patients with PD-L1 being greater than 50% of stage 2 and 3A patients, excluding those with mutations, was significantly higher than those with less PD-L1 expression. Different to this trial is the Keynote-91 trial, which also treats in an adjuvant setting patients following surgery with pembrolizumab. Looking at disease-free survival of these patients, there was a little better survival of patients being treated adjuvantly with pembrolizumab, but patients with PD-L1 status of over 50%, there was no significant advantage as compared to patients that did not have a high PD-L1 expression. And looking at the overall survival, which is kind of interesting too, in this trial there doesn't seem to be a significant survival benefit for the adjuvant treatment of these patients. There are some limited things when we include patients into the clinical trials, and as shown here and used as an example is the Empower 010 trial. Patients can only and were only assigned when they were completely resected. Well, as shown in Europe and Asia, many of the patients are completely resected, but the R0 resection number is not as high in the United States so far. This also, they had to be given cisplatin, and by far not all of the patients are treated with cisplatin. In Germany, as shown here, only 28% of all of the patients following the surgical therapy will be treated with a platinum chemotherapy. And looking at those 28%, only about 20% of these will have a PD-L1 status of about 50%. So in the end, only a very little number of about 5 to 10% of all of these patients will be applicable to be put onto these into these trials. Also, looking at the selection of the patients in the Empower 010 trial, just looking at our own cohort of patients that are stage 3A and have N2 lymph nodes, when you look at the survival of patients that are treated adjuvantly with chemotherapy, the survival of these patients is a lot better than those patients that did not receive any chemotherapy, as shown here. Now, in the Empower 010 trial, only patients that got chemotherapy are looked upon in this cohort. So there is a selection bias when you talk about these patients put in the trial here. And furthermore, in the upcoming trials, it will be very difficult to tell whether or not there will be a benefit by a neoadjuvant therapy with chemotherapy and immunotherapy, as in all of these trials listed here that are recruiting, all of these patients will be treated after surgery with adjuvant treatment. So there is kind of a mixture of neoadjuvant treatment plus adjuvant treatment in all of these trials, making it very, very difficult to really figure out and pinpoint whether or not advantages in survival will be due to the neoadjuvant setting or to the combined adjuvant and neoadjuvant systemic therapy. So taking together all of this information, the local therapy for stages 1 and 2, which was kind of the case about 10 years ago, has now changed completely, as many, many patients are put into trials, multimodal chemo and immunotherapy trials with stage 1 until stage 4. And so I think we need to make decisions on a multimodal therapy concept on how we will be treating our patients that are stage 1 till 3 and maybe treated surgically. So for us, the way to treat patients is if we have patients with clinical N1 situation or clinical N2 situation prior to surgery, we will try to put these patients into trials with neoadjuvant chemoimmunotherapy. If the tumor is larger than 5 centimeters, with a T3 or T4 tumor and no sign of lymph node involvement, we also will try to put these patients into neoadjuvant chemoimmunotherapy trials. Patients with clinical no sign of lymph node involvement or pathological N1 or N2 lymph node involvement following surgery, we will put those patients onto adjuvant chemo and immune maintenance therapy. And patients that are not listed in these trials, that have got central tumor necrosis, that come up with hemoptysis and melting of the tumor, that cannot be treated systematically with chemotherapy or a combination of chemo and immunotherapy, will be primarily operated in our setting here, and then will receive adjuvant chemotherapy in combination with immunotherapy later on in an adjuvant setting. So wrapping up, I should say that pre-therapeutic histologic confirmation and lymph node staging is essential really to think about neoadjuvant immune and chemoimmunotherapies given to our patients. The neoadjuvant chemo and immunotherapy in clinical stage 3 is to be thought about as a new therapeutical standard, and will at least show in many of the patients treated this way a high amount of patients with a major pathological or complete pathologic response. The technical demands on patients treated in a combined matter with chemotherapy and immunotherapy and surgery is increasing demanding and will for sure lead kind of to a change to more and more patients, I guess, being treated in a robotic way. Still, it is unclear whether the adjuvant therapy, and especially the immune maintenance, will show and lead to a longer survival of the patients. I hope that the new trials will show and give us some information on this. The role of radiotherapy in operable stage 3 must be redefined, and it's important that clinical observational studies are performed to optimize and personalize the multimodal therapy concepts for patients with stage 2 and 3. This and view over Heidelberg and the Neckar, I would say thank you for for attending this lecture, and I hope you've got some questions for me to follow. Have a good evening.
Yeah, thank you, Hauke, for this excellent overview covering a lot of aspects of perioperative immunotherapy. There were several questions coming up regarding restaging. You mentioned some of the difficulties with nodal immune flare And the question was, is there any way to predict which patients develop pseudoprogression or nodal immune flare, and probably what is the best way of restaging? Will it be imaging? Will it be other means? What's your opinion on that?
So when we use what we have been using for the last trials, the PET-CT scan, then we often kind of are intrigued by the immune flare. All of the patients that showed the immune flare so far were negative for tumor involvement. We have so far no way to predict who of the patients will develop immune flare and who of the patients will, in the end, have got major or complete pathologic response. We're trying hard, as most of the other trials too, to define the infiltrate with immune cells to be able to predict who of the patients are those to be treated in this way. But so far, we have no idea really to predict therapeutic adherence.
And if imaging is not really a reliable method, are there probably other means of restaging that might be more important? Is it invasive restaging? Are there some blood-based biomarkers that might be used as an alternative?
Hopefully, these will be important ways to define whether or not the tumor has evolved or not. But so far, there is no marker that can be checked out in the blood or by PET-CT or by CT scan to really predict. There are possibly other PET scans, not FDG PET scans, but other PET scans that might help. But so far, there is nothing out that I'm aware of.
What do you think about circulating tumor DNA?
Yes, we are looking into this too, but so far, in my knowledge, there hasn't been any data really showing that this will help to predict which of the patients have really shown a good response to the immunotherapy.
An old discussion has probably gained some new interest with the immunotherapy now with regard to the resection extent. Do you think the resection should be guided by the initial tumor volume or by the tumor volume after neoadjuvant therapy?
Again, this is an excellent question, but almost impossible really to give a very good answer. My eyes, yes, I think we should always look at the primary scans and resect the amount that was shown in the first pictures. Because although the pathologist might not be able to retrieve any still living tumor cells, I think we need to resect what has been infiltrated prior to any surgery, prior to any immunotherapy or immune chemotherapy.
Is there, another question was whether there is a difference in perioperative complications, morbidity or mortality between neoadjuvant immunotherapy versus immunochemotherapy?
So it's the trials so far, is looking at the CheckMate 816 trials and all the immunotherapy trials, I think it's likely to see more toxicity when you combine chemotherapy and immunotherapy, especially when the immunotherapy is not only one component like PD-L1, but if you add CTLA-4, the likelihood of increasing the toxicity is for sure there. How much this will improve the survival of the patients, we don't know yet, because those trials are not long enough out to really know how it translates into longer survival.
And with regard to bronchial stump ischemia, there was another question whether this is increased after neoadjuvant immunotherapy or whether there's no difference with regard.
So far, it has not been shown, neither in all the patients that we've been treated, which are now about 40 patients in immunotherapy trials, neoadjuvant trials, nor in those other trials that I'm aware of. So bronchial stump insufficiency were not shown to be a problem. But for sure, a big problem are all those colitis patients or the other problems that evolved due to the immunotherapy.
There was a question of the time interval after surgery when adjuvant immunotherapy can be given, and this is probably also interesting in the neoadjuvant setting. What should be the optimal interval between neoadjuvant therapy and surgery?
So for us, it was always, and that's the most of the trials that I've shown. I think we should try to keep the interval between the chemotherapy or the chemoimmunotherapy as short as possible, and not to extend it for too long. So what we tried always is to have a lag in between the last therapy interval to the surgery for 2 to 3 weeks. But in those patients that develop some side effects or problems, that might be a little longer. For the duration of the adjuvant therapy, nobody really knows whether we need a whole year of adjuvant therapy or whether half a year is good enough or a quarter of a year. But this has to be shown. It's very difficult because most of the studies at the moment, they all include an adjuvant therapy scheme of at least half a year to a year. But whether this is really necessary or not, nobody knows.
And one bit maybe problematic issue with the majority of the large studies is that several stages were summarized in the same treatment algorithm, which were now treated differently, particularly stage 1B and 2 versus stage 3. So what would be your recommendation, or yes, if an approval of the neoadjuvant therapy will be issued, for which stages should it be given, or what should guide our selection?
I think if no lymph nodes are involved, as I tried to show, wrapping up, I think we have to be very careful to treat the patients that can be treated surgically with no lymph nodes by immunotherapy or chemotherapy, because the likelihood that these will develop some severe side effects is pretty high. Also, there's a high amount of patients after chemoimmunotherapy that will not develop their problems right away, kind of the next week or 2 weeks after giving the immune chemotherapy, but half a year later. So with those very early stages, I'm very reluctant to give those or to put these patients onto these trials. With those with positive lymph nodes, yes, for sure, I think these are the right ones, and for those with large tumors.
Another issue which has just been brought up is the surgical attrition rate after neoadjuvant therapy. There's been quite a high dropout rate, as you've shown, for example, in the Checkmate 816, not so much in other trials. Do you think this is due to a lack of thoracic surgical expertise in the initial multidisciplinary selection of the patients, or are there other issues?
You mean the Checkmate 816 trial about the dropout and the high rate of R1? Yeah, I think this is a severe problem, but I'm not 100% sure what the reason for this is. I think it's good to see that at least in Europe, the patients that were included and all those patients in Asia have got a very high quality with very low R1 and R2 resection rates. I think in the United States, I guess those centers should be more focused where patients are included into the trials, but I don't know what the problem there was.
Yeah, there's also some differences between the US and Europe with regard to the approvals for adjuvant therapy now. For example, in Europe, adjuvant therapy is now only approved with a PD-L1 rate above 50%, whereas in the US it's 1%. Right. Do you think, what do you think in the end will be the better way to move forward, and do you anticipate these differences also in the neoadjuvant setting?
It's a good question, but difficult to answer. As shown in the last 2 trials, adjuvant trials, in one trial it seems to make a big difference that PD-L1 expression is high, in the other one it doesn't seem to matter. So I think we don't really know whether this is a surrogate marker for therapeutic efficacy or not. I can't tell you, Clemens, I don't know really. but I guess that we don't need 50% expression rate. I think a positive expression rate, at least 1% or plus is good.
There was another question on additional radiotherapy, chemoradio immunotherapy. There's a limited number of trials. It's mainly phase 2 trials addressing that topic. Do you have any opinion on that?
Not much experience on that, so no, I think I'm not the right one to ask.
Well, it's the question was by Stefan. I mean, in Essen, based on the ESTS trial, we had some experience with adding immunotherapy ESTS trial, and interestingly, the immunotherapy somehow seemed to a bit reverse the fibrotic effects of the radiation therapy, but we'll have to wait for the final results with regard to that, I think. There's another question whether in the restaging the Y prefix is used for immunotherapy as well as for chemotherapy.
Yeah.
Okay, are there any other questions from the audience? So it is a bit surprising given the biology of immunotherapy, which should be advantageous in the neoadjuvant setting, that there is actually only one phase 3 trial addressing neoadjuvant therapy only, which is the Checkmate. There are several perioperative and several adjuvant trials as well. Since there is no direct comparison between these approaches, what do you think will there ever be a reasonable comparison, or do you think we will just approach in a differentiated way like you presented at the end, what you're doing now at the moment?
Again, difficult to find the right answer here. I think, and I very much hope that we will see and get more large trials where we randomize patients to really try to pinpoint whether or not we see an advantage for the patients, and also to try to figure out which stage of the patients is the right one to include into the studies. With kind of a large variety at the moment always being included is kind of very difficult, especially with different N2 and 1 lymph node stages. It's very difficult to really compare these trials so far. But I guess we need to see and have more of those large trials.
Yeah, that's the interesting part, that a lot of questions still are open. Another interesting question came up with regard to blood transfusion in the perioperative period who received neoadjuvant immunotherapy. Are there any data on complication rate or issues with regard to that?
I don't know, probably somebody knows better than I do. I cannot give you information on that.
I'm not aware of data either at the moment, but it's definitely an interesting question. So what's your current mode of restaging prior to surgery after neoadjuvant chemoimmunotherapy, if it's not defined by the trial?
So we always perform for those patients that we have on our trials another PET-CT scan and also CT scan with contrast medium prior to surgery. We do not always, and most of the time, do not perform any EBOS-TBNR to make to look for those possibly positive lymph nodes that we have seen in several of the patients, as shown with the immune flare.
Okay, thank you very much, Hauke, for this really excellent presentation and a very interesting discussion afterwards. I'd like to remind all of you that it's possible to watch the webinars in replay as well for ESTS members via the ESTS homepage. The next webinar will be on January 16th, and it will be held by Harry de Koning on the implementation of lung cancer screening in Europe after the Nelson trial. I hope that many of you will be participating as well. And until then, I wish you all a Merry Christmas, nice holidays, and Happy New Year.
Thank you, Clemens. Have a good Christmas too. Bye to all of you.
Bye-bye.